Hello and welcome to Pharmacology of Depression. Myself, Mohi Iqbal Muhammad Abdul, a faculty at College of Pharmacy, Taiba University. This lecture was given to medical students, and I thus thought of replicating and recording it and publishing it online so that others can get benefited with it. Well, other lectures can follow depending upon the interest, depending upon my availability, and more importantly, the reviews I get on these lectures from you guys. All right, let's get started with the definition of depression. WHO defines it as a disease characterized by sadness, loss of interest, loss of pleasure, feel of guilt, low self-esteem, disturbed sleep or appetite, feelings of tiredness, and poor concentration. And this is one of the very common mental disorder which is seen in Western world. It is also called major depressive disorder or clinical depression or depressive disorder. Now, coming to treatment of depression, it depends upon the type of the disease itself. For instance, if it is mild or if it is mild to moderate or moderate to severe. So depending upon this category, you have the treatment goes with. In terms of mild, perhaps you don't even need any treatment. And basically, you advise patient for exercises or join some social groups which can talk to each other who are in the same boat and could be helpful to each other, that could like increase their mood and other things. Now, mild to moderate, even there perhaps you don't need any treatment. You can still go by exercises, social groups, plus in addition to that you can refer patients to a special therapist called cognitive behavioral therapist. So this guy, actually the therapist, has a session with the patient and tries to look into the thoughts the patient is going through. So usually the depressed patients have negative thoughts and that relates to negative actions. So this therapist, it devises a plan to the patient and works with him to convert his negative thoughts to positive thoughts so that he can put those um, uh, thoughts into actions which are more positive and that could increase the self-esteem of the patient. So basically, the whole idea is to change the negative thoughts to positive thoughts, and that's how you make patient feel better about himself. Now, in case of moderate to severe depressive disorder, that's where you would need treatment. And plus, you can also do all those things, exercises, social groups, plus CBDs. Plus, you can refer patient to some focused teams, which involves a whole bunch of specialists like psychologists, and then you can have nurses, you can have occupational therapists, and all of them work together for the betterment of the patient. Now, let's get into the antidepressive medications. The depression therapy revolves around one hypothesis. We call it as amine hypothesis. What it basically says is the mood of the patient depends upon the levels of some monoamines, especially two amines here, or in other words, they are neurotransmitters. One of them is norepinephrine and another is 5-HT. So what it says, if there is an increase in these levels of these amines, the mood is better and the patient is more happy and is not depressed. It goes other way around. If the levels of these amines is less, patient gets into depression and sad. So the therapy of depression goes, the target is to increase the levels of these amines, 5-HT and norepinephrine. And again, it can be at two different levels. One is at synapse itself, that's at the synaptic junction of the two different neurons, or at the synaptic neurons. So that's the target of the treatment. Anyway, there are a lot of limitations to the amine therapy. There are a lot of unanswered questions. But anyway, the drugs which are targeting the amines are clinically used with success in depression. So we're not getting much into those negative stuff. All right. So coming to the classification of the drugs. Starting with the very classic drugs, which were first to be effective, are tricyclic depression drugs, amitriptyline and so on. And then you have another class of drugs we call selective serotonin reuptake inhibitors. And then the third class is mono amino oxidase inhibitors. All right. And then the last one, but not the least, are atypical drugs. Antidepressive drugs. They are, as you said, which are the first class of the drugs, and they are basically amines, and it could be tertiary amines or secondary amines. And tertiary amines basically act on both the amines, norepinephrine and 5-HT. They increase the level of these two at the synapse. How? We will come up to it later, basically by inhibiting the transport of these amines. Whereas selective serotonin reuptake inhibitors, they do the same thing, but specifically they act on 5-HT. So they increase the level of only 5-HT at the synapse. Now coming back to tricyclic antidepressant secondary amines, they do the same thing, but specifically only for norepinephrine. All right. So these two categories of drugs, right? They increase the amine levels at synapse. All right. Now coming to monoamino oxidase inhibitors. So these drugs, what they do, they inhibit an enzyme called monoamino oxidase, which basically metabolizes three different amines. First is norepinephrine, 5-HT, and dopamine as well. There is a difference. These two amines get metabolized by monoamino oxidase A enzyme, whereas dopamine gets metabolized by monoamino B enzyme. So some of the drugs, or most of the drugs you can say, target both of these enzymes and thereby increase the concentration of all of these three amines. But there is a slight difference in the site where they increase the concentration of this amine in comparison with tricyclic antidepressant and SSRI. These drugs increase the concentration of amines in presynaptic neurons, Right, coming to atypical drugs. These drugs are structurally and mechanistically diverse drugs. They are not related to each other. The advantage of these drugs, they focused on lowering the side effects of the all other classes of antidepressant drugs. They have minimal side effects. Atypical drugs are new classes of drugs, right? They're newer drugs, newer treatments, more expensive, but better side effect profile. In terms of efficacy, they are almost same as any of those drugs. All right, coming to tricyclic antidepressant drugs, like we already said, like they are like tricyclic is like tertiary or secondary, right? Basically, these drugs have more side effects because apart from acting on both of them, apart from acting on the increasing the norepinephrine and 5-HT, they also has the effects on various other receptors. For example, adrenergic receptors, or they have anti-muscarinic receptor, anti-muscarinic activity. They have antihistaminic activity. Okay, so adrenergic accounts for their cardiovascular problems mainly, hypotension and those kind of things, or arrhythmias and those kind of things. Anti-muscarinic is basically it gives them atropine-like side effects. Antihistaminic usually it gives them more kind of sleepiness and other things, and plus because they also act on 5-HT, they have GI side effects and other things. We'll come up to them later. In terms of route of administration for these drugs, most of the antidepressant, it is not only tricyclic but even all other drugs are given orally. Exception are amitriptyline. Exceptions we have is amitriptyline and imipramine. They can also be given as injections. And in terms of metabolism, they are metabolized by liver, excreted through kidneys. Alright, so let's look at the mechanism of action. Help of a figure that would make more clear perhaps. So basically, normally what happens, the neurotransmitter gets released, right, acts on the receptor, and then again taken back by the neuron into the presynaptic neuron. So that's what we call reuptake. So for this reuptake, it is done by some specific transporters, or in other words I would call them buses, like transport cars or buses, whatever it is. So tricyclic antidepressants mainly inhibit these transporters so that more of your amine stays here for a long time. So that is at the synapse, you have more of the amine to act on. So that's what it can elevate the mode. Alright, coming to the specific drugs. So tertiary amines are structurally related, and we already said that they kind of act on both norepinephrine and 5-HT neurotransport system, right? So amitriptyline is the classical drug, and then you have other drugs as well. Then secondary amines are structurally diverse. They don't have a specific relation among the drugs, but still they all of these drugs selectively interfere with the transport of norepinephrine. Now, in terms of the side effects of all depressant drugs, we can classify them into these side effects like agitation, seizures, sedations, so whatever it is. So these first three are CNS related, right? And of these, the first two are related to increase in dopamine. So drugs which increases the dopamine as well will cause these ones. And hypotension is basically adrenergic action on alpha receptors, adrenergic receptors, right? Cardiovascular. We already talked about anticholinergic, that's because of anti-muscarinic effects, right? Then you have GI side effects is basically for 5-HT effects, but on 5-HT at GI level. And weight gain is again related to mostly steroidal things. Then sexual side effects is again related to 5-HT kind of drugs and steroidal things. Again, cardiovascular is adrenergic base. So with these, irrespective of tertiary or secondary tricyclic antidepressants, you see most of these drugs you have ticks on many different classes. Maybe they are okay with GI side effects, but they do have many other side effects. So that's the side effect profile of these drugs. Now coming to toxicity of these drugs. Toxicity is something where the dose is more than that used for treatment, or more than the therapeutic doses, like comes to the toxic dose. That could be because of the interaction, or could be because of starting with the more doses given to the patient. Well, it's kind of common with tricyclic antidepressants because these drugs have narrow safety margin. So that's the major problem with tricyclic antidepressant drugs. They have narrow safety margin and also has serious side effects in terms of coma, convulsions, cardiotoxicity, right? And the drug interactions, their toxicity can be potentiated if they are actually given with alcohols, barbiturates, benzodiazepines, opioids, right? Causes more CNS depression. Then if it is given with some other drugs that can also interfere their mechanism of action, especially clonidine, methyl dopa, unithidine, that can decrease their anti-hypertensive effects of these drugs. All right, the other class of drugs, selective serotonin reuptake inhibitors. Well, they inhibit selectively the transport of 5-HT. Similar mechanism as tricyclic antidepressants. They do interfere with the transport of 5-HT, but only 5-HT. And in terms of their side effect, these drugs mainly have their side effects at GI level because of the actions on 5-HT receptors and GI. So you see nausea, vomiting, all gastric discomfort, increase in motility, on those kind of things. Plus you see also sexual related side effects. They are basically decrease in libido, or decrease in satisfaction, sexual satisfaction, right? So these are the side effects related to SSRI. They are given orally, no injection, and then metabolized in liver, excreted in kidneys. And some of the drugs, for example, fluoxetine gets converted into active metabolite, and which has a very long half-life. And the half-life of these drugs ranges, T-half, from 18 to 24 hours. Okay. All right. So mechanism of action. So similar mechanism as tricyclic antidepressant drugs, but the target is 5-HT increase at the synapse. So more 5-HT at the synapse, so better mood elevation. In terms of their dosage, these are their regular dosage. So there's no specific, different drugs have different dosage thing, and some of the drugs can also interfere with norepinephrine reuptake as well in this class. Right, coming to the side effect profile. So now if you just compare their side effect profile with tricyclic antidepressant drugs, here majority of the tics are gone, and as we said earlier, where most of the side effects are revolving around GI side effects and sexual side effects, and all other things are minimized. Good. Now toxicity, we're talking about overdose of these drugs, then we could see some sort of seizures, some sort of prolongation in QT intervals, that's cardiovascular side effects, and more importantly, one of the things we normally see as side effect, not as toxicity effect, but it's like withdrawal syndrome. By once you abruptly stop these drugs, then the patients can get into this nausea, dizziness, and other things. And serotonin syndrome, that's a toxicity thing. It is very life-threatening. That involves seizures, muscle problems, and all other things. So the treatment with this goes in the reverse order. For example, if you give, you can give anti-seizure drugs to come back with the seizures. And drug interactions usually is potentiation of the actions of SSRIs that could happen with monoamino oxidase inhibitors when these two drugs are given together, or even tricyclic antidepressants are given together with these drugs, and some of the herbal medicines and some of other drugs. Now, the third category of the drugs, monoamino oxidase inhibitors. So, monoamino oxidase inhibitors basically are two types, right? So, one which specifically act on monoamino oxidase A enzyme, inhibits that. So basically in that case it interferes with the metabolism of norepinephrine and 5-HT, right? And then you have another class, monoamino oxidase B. So it basically interferes with dopamine metabolism. Most of the drugs act on both monoamino A and monoamino B, and there are certain drugs, for example selegiline, which acts specifically on monoamino and has minimum effect on monoamino A. Okay, so the mechanism of action of monoamino oxidase inhibitors. So what happens, these drugs now, as we asserted earlier, act at synapse, not at synapse but at the presynaptic neuron. So that's where your amine gets reuptake, it gets reuptake, gets inside your presynaptic neuron, and then gets metabolized by this enzyme monoamino oxidase, right? So the inhibitors of these enzymes will destroy this enzyme, and then you have free or undestructed amine, either 5-HT or norepinephrine or dopamine, stored more into your vesicles. So when there is a stimulus again, as you have more of the amines, they are released more into the cycle. Well, so monoamino oxidase inhibitors and their dosage, again they are variable. Selegiline, for instance, is used about 10 mg per day. So the reason behind it, like at the more dose it acts on, or a dose more than 10 mg or equivalent to 10 mg, it acts on both monoamino A as well as monoamino B. So that's what selegiline dosage in depression. But when it's given in Parkinsonism, it's also given in Parkinsonism. In that case, we give the dose less than 10 mg. All right. Now, looking at the side effect profile now, if you just remember the comparison with the SSRI inhibitors, right? Then here you have minimal tics again. So for example, selegiline, it's pretty much it's like free from all the typical side effects of antidepressants, right? Including GI side effects are gone, sexual side effects are gone. So that's kind of a better in terms of efficacy, is still same to other drugs. Toxicity because of these drugs: shock when you have giving more dose, so shock due to low BP, hyperthermia, seizures can also happen. And the drug interactions, again we already talked about it, like especially it's when they are given along with SSRIs, then you can get it, that the patient get into serotonin syndrome. Now coming to atypical drugs, as we said, they are atypical and not related to any of the drugs. They're not related to the other drugs in terms of structure or mechanism. And again, the dosage really varies, because that's understood because of the structural variability perhaps. Now atypical drugs, they have different mechanisms. Some of them are analogs of 5-HT, right, with antagonistic effect. You have some examples, and then you have some of them could be inhibiting the reuptake of 5 of norepinephrine only, and some of them reuptake of 5-HT specifically, and some of them are antagonist to alpha antagonist to alpha 2 receptors. So these agents can increase, by doing so they can increase the presynaptic release more of the amines by having antagonistic effect on alpha 2 receptors. Alright, in terms of side effect profile, again, exception to bupropion. Bupropion has more agitation and seizures, so it shouldn't be given to those patients who already has those problems. But the reason behind this is like increase in dopamine, because this selectively increases dopamine levels. Whereas you can see most of those drugs, and then and you have like many zeros, like the side effects are almost minimal in all the typical side effects you see with antidepressants, right? And then the drug here, mirtazapine for instance, also has, most of them are zeros, but sedation is basically because this is a antihistamine, or it acts on histamine receptors, right? Because of these antihistaminic effects, it causes more sleep induction. Perhaps it actually goes as a part of the treatment plan as well for some of the patients. Alright, so the general pharmacological actions of antidepressants. So we already discussed all of these, but just a snapshot. So most of these agents do interfere with amine uptake block, specifically 5-HT and norepinephrine, right? And they can induce sedation, especially acting on 5 histamine receptors. Then they can cause muscarinic blockage, and more again with tricyclic drugs. CNS effects because of adrenergic actions basically. Then seizures, again because of CNS effects, and mainly seen with decrease in the threshold for seizures, and it usually happens with high dose for almost all drugs in this class. The clinical uses, all of them have their usage in depression. And then some of those drugs which we listed now are actually can be used in some special cases. For instance, tricyclic antidepressants are mostly used in patients with psychomotor retardation, sleep disturbances, because we want them to sleep more, or poor appetite, or patients who are losing weight and you want to gain them weight. And similarly, monoamine oxidase inhibitors are used specifically in patients with anxiety, phobic features, and hypochondriasis, basically the patients who are not happy about their health status and those kind of things. Selegiline is used in Parkinsonism, as we already discussed. The dosage here is usually less than 10 mg per day, right? And SSR, known to decrease weight, hence are preferred in obese patients, or patients with overweight patients. In terms of relative toxicity, so very high is usually seen with tricyclic antidepressant drugs, right? And high, or it can be seen with mainly with hypotension and other things, monoamine oxidase inhibitors, especially also with some special diets containing tyramine containing diets. So these are the risk is high in those cases. Whereas other drugs, bupropion and other drugs, are comparatively low toxicity and hence are used better. Okay, thank you very much for this one, and that would end the lecture on antidepressant, and hope you will enjoy it and it adds to your previous understanding. And please do leave your comments and subscribe to this thing. Thank you very much and see you again.